Hi, I'm Ruth Stewart. I'm the Associate Professor of Rural and Remote Medicine with James Cook University, and it's my pleasure to speak to you today about teamwork and continuity of care. This is Module 9 in the subject MD8023, Masters of Rural and Remote Medicine at James Cook University. In this module, we will consider communication and teamwork, continuity of care, as it relates to patient transfer and evacuation, discharge and referral in rural and remote medicine. Let's begin with patient transfer and evacuation. In 1996, the Royal College of Physicians and Surgeons of Canada adopted CANMEDS, a medical education framework that emphasises the essential competencies of a physician. Since its creation, CANMEDS has been adopted and adapted around the world. It's useful for us to consider the CANMEDS framework when we're thinking about the doctor as a communicator. So let's look at what CANMEDS has to say about communication. CANMEDS 2015 Competency Framework has the collaborator. The collaborator will hand over care of a patient to another healthcare professional to facilitate continuity of safe patient care. The collaborator will determine when care should be transferred to another physician or healthcare professional and will demonstrate safe handover of care using both verbal and written communication during patient transition to a different healthcare professional setting or stage of care. At the Australian College of Rural and Remote Medicine, in the core curriculum 6.4 Anaesthetics, Domain 7, the curriculum states that the rural and remote doctor should be able to arrange referral to a distant service in concert with the patient and or carer, considering the balance of potential benefits, harms and costs. As George Bernard Shaw said, the greatest problem in communication is the illusion that it has been accomplished. So you need to make sure that when you communicate, both sides of the discussion understand what has happened. So, for patient transfer and evacuation in rural hospitals where there are rural GPs with community and hospital practice, those doctors who work across both hospital and community practice can be pivotal points of care continuity. So it's about getting the right patient to the right healthcare team at the right time. The Australian Council on Safety and Quality in Healthcare has defined clinical handover as the transfer of professional responsibility and accountability for some or all aspects of care for a patient or group of patients to another person or professional group on a temporary or permanent basis. Clinical handover can occur between clinicians in the same team, or transfer of patient to another team of clinicians, or it can be to provide a clear picture of a patient's current status. A clinical handover transfers authority over and responsibility for the patient and that patient's care. The exchange must include relevant, accurate and patient-specific information. The accuracy and style of handover is essential to the success of the handover. Get it wrong and you've wasted your time. What are the problems in communication in handover? It's one of the top 5 contributing factors to sentinel events in Australia and worldwide. Problems of communication in handover in Queensland represent 20% of all reported public hospital sentinel events, especially in the staff-to-staff communication problems. if you increase the number of people caring for a patient, you increase the risk of miscommunication. So what are the successful communication strategies? How can you do it better? It's important to have a structured approach. That way you're less likely to forget things. You've got to include the important data elements, and we know that it makes a big difference if you combine oral and written communication. I'm going to refer now to a study from 2005 by Pothio, Montero, Mukhtiar and Shaw. They studied 5 consecutive nursing handover cycles, and they found that verbal and printed communication in the handover meant that there was minimal data loss. But listen to this. If there was note-taking during the communication, 69% of the data was lost. If there was verbal handover alone, so without any printed communication, written communication or note-taking, let me repeat that, all of the data was lost within 5 cycles. Now, I think that's really scary. What are the attributes of effective clinical handover? So it's good to have face-to-face communication, look them in the eye. That allows the possibility of questioning and verification. If you say something and I don't understand it, if we're looking at each other, it's much easier for me to ask you to explain the bit that I don't understand. There needs to be sufficient time allowed for communication and information exchange. If it's rushed, I won't feel enabled to ask you for clarification and you might forget things as well. If there's a common language and a standardised approach, that helps both the person delivering the information and the person receiving the information order it and recall it, and ensure that all of the information that should be transferred is transferred. Forms and checklists that can be physically handed hand to hand are useful as well. But if you structure that with a narrative. Mrs. Smith is a 75-year-old lady who's really fun. When you get her talking, she laughs. She's here because she's got congestive cardiac failure that isn't responding to the medication she's on. We're trying to change her medication. We've increased her ACE inhibitors and she's had a diuresis, that sort of thing. Now, there are a couple of different structured approaches that are commonly used. The most commonly known one is often referred to as ISBAR. It's a standardised approach to communication about patient care that can be used in any context. I is for introduction, who you are, what your role is, where you are, and why you are communicating. S is for situation. What's happening at the moment? It's 1 o'clock in the morning, there's a strong wind blowing, we're having trouble getting a helicopter in, but I have this patient, that sort of thing. The background. What are the issues that have led up to this situation? Now that might be, I mentioned a weather situation, so the situation could have been that Mrs. Smith has not responded to the medication change and her blood pressure is dropping. You feel that she needs inotropes. You don't deliver inotropes in your hospital. Assessment. What do you believe the problem is? Mrs. Smith is going into cardiogenic shock. Recommendation. What should be done to correct the situation? You need to be specific. I want this patient transferred to intensive care, please. We don't have an intensive care at my hospital. That's why I'm ringing you. ISBA. Introduction, situation, background, assessment and recommendation. There are various ways of representing those. I've offered you 2 different representations that you can look at. I find it useful to have at least the identify situation, background, assessment and recommendation in front of me. It helps me structure my thoughts. Another tool that was developed in Queensland is shared. It's another structured communication tool. Situation, the reason for the admission or call or change in condition. History, the important information relevant to the patient's current presentation. You don't need to go back through everything that's ever happened to the patient. Assessment. So, what you think is relevant to the patient's current presentation. What you think is happening. The R is for risk, such as allergies, infection control, literacy or cultural issues, drugs, skin integrity, got an ulcer in the left heel, elderly, frail, needs a walking frame to walk, that sort of thing. Expectations, what I'm hoping that you will do in response to this communication. I'm hoping that you will accept this patient for admission to your intensive care unit. And then finally D. D is for documentation. Got to write progress notes, the care path, referral letters. It's important that this is you put in the relevant information and not the irrelevant information, that it's written in the appropriate place so that others can find it. Let's talk now about discharge and referral. The New South Wales Government has published in 2011 Care Coordination, Planning from Admission to Transfer of Care in New South Wales Public Hospitals. I think it gives a really useful structure for planning discharge. If you click on the hyperlink at the bottom of the screen, you can have a look at this document online. What it emphasises is that you don't begin your planning for discharge when you make the decision to discharge. You should start the planning for discharge when you admit the patient. New South Wales Health has defined 5 mandatory requirements. So let's have a look at those 5 stages. The first one is at pre-admission or admission. So you're already beginning to think about discharge as the patient is admitted. Then the second point is at the time of multidisciplinary team review, so that as a whole group, the multidisciplinary team considers when and how discharge should occur and what that discharge plan might look like. Because if it's just perhaps, say, the doctors deciding how discharge should occur, they may not be thinking about perhaps occupational therapy assessment of the home for the patient that may be needed, or whether the patient will have adequate strength in their lower limbs to stand, having spent 2 weeks lying down in bed, that sort of thing. Then the third point is the estimated date of discharge. The fourth one is the referrals and liaison for the patient transfer of care, so that people to whom care is being transferred are ready for that transfer. And you think about when and how that transfer will best be done. For example, you don't transfer a patient home on a Saturday if they're going to need some new equipment at home, because it probably won't be provided on a weekend. And only when you've been through those 4 steps do you think about the actual transfer of care out of the hospital into the community. So there you have it, the 5 mandatory requirements of planned discharge, or as New South Wales Health calls it, care coordination, planning from admission to transfer of care, and they are 1. Pre-admission, admission planning. 2. Multidisciplinary team review. 3. Estimate the date of discharge. 4. Conduct the referrals and liaison for patient transfer of care. And 5. Transfer care out of the hospital. Hope you find that useful too. Now, we've talked about the whole process within which the communication of discharge should occur. Let's think about the referral letters. Now, before we talk about that, I'm going to acknowledge that referral letters can occur, yes, at discharge, but they can also occur in the community between a general practitioner and a specialist or outpatient clinic, but they can just as easily be from a GP to an allied health practitioner. Now, the Royal Australian College of General Practitioners has set standards for referral documents, which are very helpful. They're found within the standards for general practice published by the RACGP. So criterion 1.6.2 is that referral documents to other healthcare professional providers should contain sufficient information to facilitate optimal patient care. And there are a series of indicators. Why don't you hit pause now and read these indicators in your own time. When you're ready, hit play again and you can listen to me. A couple of points that I wish to highlight. The first dot point, I'm sure it's the first because it's so important, referral letters must be legible. There must be at least 3 approved patient identifiers, such as the patient's name, date of birth, address. Unique record numbers can be useful as well, but there should be 3 points of reference so that we can all be sure that we're talking about the same patient. It's important to include relevant history, examination findings, and current management of the patient. Include a list of known allergies or state that there are no known allergies. Same for adverse drug reactions. And also an up-to-date list of the medications that the patient is taking. Now sometimes people say, oh, but the patient doesn't have any allergies or is on no medication. If that's the case, it doesn't take very much to say no known allergies, no medications. That saves the receiving practitioner going looking for a list of either of those because you haven't mentioned them. You need to properly identify yourself as the referring doctor. It's important to identify who you are, where you are, and what your position is. Even if the doctor who you are referring to knows you quite well, maybe a personal friend, but you don't know that the next person to read that referral letter is going to be your friend who knows you and will be able to recognise your handwriting from, if I sign a letter as Ruth with my handwriting to my good friend who's a physician in the next door town, my friend the physician will know who Ruth is, but the locum who's in the practice in 2 weeks' time won't be able to know who to ring when they've got further questions. I've said you need to identify where you are, but it's a good idea to stipulate what the healthcare setting is from which you're making a referral. Is it a general practice? Is it an Aboriginal Medical Service? Is it a remote hospital? Is it a primary healthcare clinic on an island in the Torres Strait? Or is it a clinic in an inner suburb that has a specific scope of practice? It's a good idea, whenever possible, to be very specific about who you are making the referral to, if you are choosing a particular person. So once again, thinking about referring to your good mate Bob up the road, don't just say, "Dear Bob." Say, "Dear Dr. Robert Smith, General Physician, St Elsewhere's Hospital," that sort of stuff. And now, this is really important in the current, in our New World Order. If you are making an electronic referral, it needs to be done in a secure manner so that the referral isn't available to whoever wants to hack into your service. Dr. Ronald Epstein, in his 1995 paper, discussed other things that should be in a good referral letter. He recommended that discussions of uncertainty should be held. What do we know and what don't we know? What are the points of uncertainty? That a discussion about the continuity of care, so where my responsibility ends and yours begins, and where I wish to take over the care of the patient again. Values of the physicians involved, and also the patient perspective and preferences. Is this a patient who wants to stay alive and continue to work in their very cerebral role and will be happy to live out that life in a wheelchair? Or is it a patient who has always led an active life, for whom the very thought of being in a wheelchair is extremely distressing? And finally, Dr. Epstein wants the referring physician to talk about the patient's expectations, the family's expectations, and the physician's expectations of this consultation. Why are we making the referral? To what end? And how is that going to help patient care? It's time for us to think about the context within which communication occurs, and to think of some of the structure that has been built around communication between practitioners in Australia in the last decade. I'd like us to think about referral pathways. Really, the discussion of discharge planning and communication isn't complete without referencing the work that has been done by primary health networks in Australia to create referral pathways. This work was begun by the Medicare locals and has continued under the primary health networks. These referral pathways provide relevant information about conditions for the local context and explain exactly what service to refer to for what conditions and in what situations. They define where the referral for a specific clinical condition should be sent and provide sometimes a template for the referral, which may be either electronic or paper-based. I'm going to put a link to a YouTube video into the Learn JCU folder for this lecture, which explains a referral pathway that is used in urban Brisbane. But the principles are very similar for many of the referral pathways in the remote and rural hospital and health services around Australia. The useful one about this is that there's a discussion in this video about the connection between the community and the receiving specialists, but also some of the value add that is given by the referral pathways, where it's almost like the frequently asked questions are addressed. I now offer that to you. I suggest that you pause this lecture now and go and look at the video. In this module, we have considered communication, teamwork, and continuity of care, as it is embodied in patient transfer and evacuation, patient discharge and referral. Thank you for listening. I really welcome your feedback because it'd be great to know how to make this lecture better. Thank you and goodbye.